Good morning, good afternoon, good evening. Welcome to today's webinar hosted by the IBP Covid-19 Task Team Group. My name is Nandita Thate and I'll be your moderator today. Next. The IBP Covid-19 Task Team is a joint group hosted by the IBP Network at WHO, along with FHI360 and the Johns Hopkins Center for Communications Programs. And we have launched a regional webinar series to follow up with some of our partners on how they are maintaining FPRH services during the COVID-19 pandemic. We are happy about today's webinar, which is the first in the series featuring some of our partners in the Asia region. Next. As I mentioned, my name is Nandita Thate. I will be the moderator today. I lead the IBP Network, which is a network of NGO, civil society, and other organizations dedicated to disseminating and use of evidence-based guidance in family planning and reproductive health. We are thrilled to be bringing this webinar series to you all today. Next. Before we begin, just a few quick notes. One, we do have French interpretation available for today's webinar session. You can select the small globe at the bottom of your screen and enter the French translation. If you want to view the slides in French, there should be a link in the chat where you can download a PDF copy of the French presentation. You can also find an English version of the presentation there. Please do submit questions at any time using the Q&A box at the bottom of your screen. And do note that the webinar today will be recorded, so we will be posting the recording in the coming days on the WHO HRP Media YouTube channel. Next. We have a great lineup today. We will start with some remarks from our colleague at the WHO Regional Office, followed by remarks and a presentation from IPPF regional perspectives. Finally, we will close with 2 country presentations, one from the Philippines and one from Myanmar. At the end, we do hope for some question and answers as well. And again, just please do enter your questions into the box at the bottom of your screen. With that, I'll go to the next slide and introduce our first speaker, Dr. Howard Sobel. He is a physician and coordinator responsible for safe and affordable surgery, quality and safety at the WHO Regional Office for Western Pacific. Most recently, he just completed deployment in Lao as acting head of office for the COVID response. So Howard, I will turn it over to you. Please go ahead. Thanks.
Thank you very much. May we have the first slide. I should mention that the reason I'm here is because I cover reproductive, maternal, newborn child, and adolescent health. May I? Thank you. So it's a pleasure to present here. I'm going to present about sustaining and improving quality of family planning services in the Western Pacific region, and I'll provide some learnings from COVID-19 based in my country I was deployed in. Next slide. So this slide is a graph basically showing contraceptive prevalence rate in the region. And you can see that we're in the highest CPR rate, country that has the highest CPR rate. We're still below 60%. And that includes, that's modern methods in this case. Next slide. This is, I wanted to start off by setting the scene. When I ask health workers around the region, what do they think is the #1 reason that people that don't want to get pregnant but are sexually active and don't use family planning, what is the #1 reason? Always, it's coming out with the cost, with accessibility, lack of knowledge, other things like that, and opposition. Well, opposition is one that is found. This is a study we did, a secondary analysis we did of 35 countries' demographic and health surveys. in 35 countries. And the number one reason that comes out across all the countries is fear of side effects and health concerns. And this is not usually thought of when I talk with health workers. The second is underestimated risk of getting pregnant. When you take those two together, you got more than half of the reasons that women don't use family planning when they don't want to get pregnant. Next slide. Now, this is, we've done assessments across the region, and you'll see some further data on this. We've developed a tool that looks at the key aspects of family planning from a health system perspective. And let's start off by looking at the amount of work that's done. On the left side, this is the total contraceptives that were dispensed. That's really a measure of work in a way. And what you can see is that 4% of the total in Cambodia of all the contraceptives that were dispensed, 4% were from long-acting reversible contraceptives. And yet, on the right side, you can see that that 4% translates into 61% of total couple years of protection. So you get a huge bang for your buck when you use long-acting methods. And this becomes very important, as I'll show later on, when we're looking at making our family planning program robust to disasters like COVID. Next slide. In our studies, we have found across countries that the opportunities to counsel women are missed all over the place. This slide here shows that Cambodia had, of all the opportunities that women presented in a facility, Cambodia did best at 48% of those women saying that they were asked about family planning at their last visit. Now this is at their last visit for whatever reason, but I should hasten to say that even when they come in for family planning, they often don't get asked questions. And that's something that we need to look at our health system to improve. Other countries are considerably worse than that. Next slide. And there's two sides to this. On the one side, women are not getting asked about their family planning concerns, et cetera. But when you then look at the quality of the counseling, you find that key, simple questions are not being asked. So you can see here that in 3 countries, in this case, it was Lao PDR, Mongolia, and Philippines, around a quarter or much less than a quarter of women that got family planning counseling were even asked about side effects or concerns. And no country is at a very high level. The best country in this case was Cambodia at 73%. So there's still a large portion of women that are getting counseling, but then the simple questions are not being asked. Next slide. This is, we look in our assessments, we look into the supply chain and we look at availability and correct storage of family planning commodities. And you can see that across the countries, there are certain ones that are not available in any of the countries at a high level, like implants, but even some of the basic things that should be available everywhere are not. And so there's only one country that had 3 of the 6 items at 100% availability. That was China. Next slide. Now, when we turn to COVID, I think this comes as no surprise to anyone that countries are reporting disruption of maternal and child health services. And you can see that they're all affected to some degree. This includes family planning, which is to the left. Next slide. Now, there's not gonna be a test on this slide afterwards, but I'm just presenting this to give a background. If you can click one more time. So in Lao PDR, they did a very heavy exercise in 2016, 2017 to define their essential health service packages by level of the system. And initially, there were many hundreds of services that were identified. Eventually, it got whittled down to 121. It took a lot of work to get it whittled down to that. Just over half of those are for reproductive, maternal, newborn, child, and adolescent health. Next slide. Now, again, no test on this slide, but I'm just showing that this was done in 2018, 2019. In Lao, they have set up a fledgling, and it's an emerging accreditation system for facilities, and there's different indicators at levels of the system, and this was data that was collected for that. And they looked at any number of things ranging from utilization, readiness, clinical quality, and then they more recently, when COVID came along, they started analyzing it to look what they could do to make, in this case, family planning robust to the pandemic. And in the first one, they looked at utilization, and it's a very small slide, but over to the right here, and I don't know if you can see that, but I'm circling it. Over to the right is essentially a distribution of where different family planning commodities were distributed at level of the system. And just so everyone is aware, the provincial hospitals and the central hospitals are being prepared to be the COVID hospitals. So they will also be the hospitals that you're going to have a pretty big impact when on essential health services if the outbreak gets to be large there. We hope not, but it's happening in all their neighbors right now. And so they looked at how many clients could be absorbed, and they said, let's look at moving them to the district hospitals. Then they looked next at, are the district hospitals ready to go? So this is, in the second slide, it says readiness. They looked at, in one province, Xinjiang, for those that know Lao, and they looked at, do they have trained people? Do they have commodities? And in this case, this was training, and the answer was yes in most, but no in one. So that tells them where they need to do some pretty heavy, quick focus. And then the other one they looked at was their commodities, and there were similar issues not shown here. And lastly, they looked at the quality of it, and in terms of whether the counseling, people are equipped to do the counseling in the right way and other measures of quality. And they found that very few of the hospitals were equipped for this. So next slide. Now, I'm not going to ignore this for the moment. I think I'm just going to conclude that what they did when they looked at this is they decided that they needed to do some very heavy targeted focus to get the district hospitals prepared to deliver LARCs. And next slide. And what you can see here in gray is 2020. Now, the whole year they've been a bit behind previous years, and that's been a reflection of basically every service. Ironically, there were no cases until late March, and yet there was a pretty big drop off even before that. So even before lockdown, even before anything, it's running below, but there was quite a big dip. And actually, it's much bigger than it appears in the slide. 2018 looks like a dip, but that was the first year they were collecting data, and there was a problem with it in that month. But when you look at this, there was a pretty big dip in it. And then they've had a sizable recovery to higher than the 2019 levels in the end. And what happened in April was a nationwide meeting was held with the provincial staff, and they worked out what they're going to do for the essential health services to make it so the district hospitals could start to perform better, but also trying to make a shift toward long-acting reversible methods. And that was, and this is implants. And so we had quite a big of a recovery during that period. Still not perfect, but quite sizable. Next slide. So this is my concluding slide, and I just want to make 5 points. The first point is that while the Western Pacific region is probably better than many regions, there's still a long way to go in improving it. The second is that we have to give people a choice, but that often I'm told that, and yet long-acting methods are not offered as a choice. And so long-acting methods are a way to be robust to anything that's coming our way, especially compared to other methods that require repeated visits and other things like that. The third is that improving access and use requires quality health facility services, but our data shows that widespread missed opportunities for family planning counseling and the quality of counseling is quite variable, and as well as the support such as logistics. The fourth point is that is obvious. I think everyone here knows that COVID-19 has exacerbated these gaps, but at the same time, as I showed with Lao, it is an opportunity for us to make family planning more robust. So we can use the term build back better in reality here. The last is that, and one that I've been emphasizing for basically my whole public health career, 20+ years, is the systematic data collection, analysis, and use through routine assessments, in this case of family planning services, but it's of all services, can help inform service continuity and improve resilience. And Lao gives a nice illustration of that. At that, I stop. Thank you very much for your time.
Wonderful. Thank you so much, Howard. That was an excellent overview of the region, but then also very interesting and helpful to dig a little deeper into the experience of Lao. Thank you very much. I'd like to go to our next presenter. Next slide. And I would like to introduce Tomoko Fukuda. She is the Regional Director of the International Planned Parenthood Federation in East and Southeast Asia and Oceania region. Tomoko, I'll turn it over to you. Next slide.
Thank you so much for the introduction, Nandita, and good day to all of you. Thank you all for joining this webinar, and I thank IBP for giving me the opportunity to share how COVID has been impacting IPPF and the member associations in East and Southeast Asia and Oceania region. So next slide, please. So I hope all of you have know IPPF. We're the International Planned Parenthood Federation. As introduced, I'm the Regional Director for the region on the slide here. It's a pretty wide region. We have 23 member associations and 2 collaborative partners working in the 25 countries. In the north, we have Mongolia. In the middle, we have Thailand, Cambodia, Vietnam, all of these countries here in Southeast Asia and East Asia. And then towards the south, we have Australia, New Zealand, and we have 9 countries in the Pacific who are part of this region. We are a federation of locally owned member associations. So globally, we have 157 member associations and collaborative partners working in 161 countries. So we're very unique in that we are locally owned. All of our member associations are national, non-government organizations, NGOs, and CSOs. Next, please. So yes, COVID has definitely greatly impacted our operations and the works of the member associations in the countries. It has really impacted us in 4 of the key areas that is up there on the slide. One is, of course, the decreased access to SRH services. So as we all aware, we've had lockdowns, there has been restrictions to mobility. It has obviously decreased the access to the services in terms of women not being able to travel to get to the clinics. Also, because of lack of, for example, protective equipment for health personnel, some of the clinics have had to close. And then, of course, there was also the fear of infecting or getting infected with COVID when visiting a clinic. So many of the clients would rather stay at home. So this has all contributed to a decreased access to the SRH services. And then, of course, there was the decreased availability of SRH services, and it links with the purple and yellow circles that I have there. I think you have also experienced and heard about the commodity stockouts and the disruptions to the supply chains, to the global supply chains have been disrupted. Commodities have not reached the places that we have supposed to in time. We are still actually waiting for some commodities to still come that have been ordered earlier in the year, just because the manufacturers are out of stock right now. So this has been a really big problem that has impacted our operations. There's also a loss of skilled workforce. In some countries, the governments have really shifted their focus on COVID and on infectious disease prevention. Some of our member associations have had to provide support to their governments in tackling COVID. Some of their health staff have gone and worked together with the governments on this. So a shift of priorities. Also, if there is an infection, it means that they cannot come and work in the clinic. So of course you would have less health staff working there. And also for example, in some of our member associations in their clinics, if they had some health staff members who were individually of high risk, they opted to have this person stay at home and not come to work during the pandemic. Of course, and there was less hours, less opening hours, spacing in the clinics, and also making clients come on an appointment basis, which would also reduce the number of people who could come and access the services. So I'm sure all of these are quite familiar with in your workplaces also, but in these ways, COVID has really impacted our operations. Next, please. So in IPPF, we took action immediately in March to really start supporting our member associations through this pandemic. We set up a task force internally between the Secretariat at the global level, also at the regional level. We worked on ensuring the continued provision of essential SRH services. Protective equipment was needed immediately so that the clinics could remain open. We made efforts to do that in the first few months. That was one of the focuses. Another focus was also to protect and promote SRHR as an essential service with the governments to ensure that the clinics could remain open even during lockdowns and other restrictive measures. So that was advocating for SRH services to be there in the national plans was our pillar 2. Pillar 3 was about building resilience of the IPPF MAs, especially when there was just severe disruptions like this, making sure that the MA, we could catch the needs of the MAs as quickly as possible. And linked with also with pillar 4 in promoting evidence generation and cross-learning, we organized bi-weekly webinars with them. We had questionnaires that we organized and to collect information on their current status to ensure that we knew what were the problems that they were facing and how the Secretariat could help them, and so that IPPF as a federation could remain strong during this pandemic. Next slide, please. So I'm going to share with you today some of the findings that we have from the surveys that we conducted with our member associations. We had 3 surveys, one in March, one in June, and the last one just recently in November. And I'll be mainly sharing from the findings that we got in November. So next slide, please. So in the November survey, we found that 92% of the MAs were impacted by the pandemic. So virtually everybody was, not everybody was affected, nobody was spared, even though we do have 9 member associations from the Pacific, and COVID has not gone to the Pacific yet, but because of the lockdowns and then the disruption in international travel and such, they were also affected also. 68% of them reported minimal to moderate, and 24% reported severe impairment of overall operations. 24% reported service delivery points that are, or 6 of the MAs reported that their service delivery points are still closed, but it has reduced down from 9 in June. Similar to what Howard presented, we also saw a severe drop in the second quarter, which is April, May, and June. So in our June survey, we saw a steep decline in the SRH services, and now we're seeing a gradual coming back up of the services, but not back to fully as to what they were before. But yes, a recovery that is looking positive. But still, so 48% of the MAs reported a decline in client numbers. Of these 48% or 12 MAs, Myanmar, Philippines, and Solomon Islands, those 3 member associations actually reported more than a 50% decrease of their clients. The MAs that were in this group were also countries like Vietnam, Thailand, Hong Kong, Indonesia, Malaysia, and some Pacific countries also like Samoa and Vanuatu. So mainly on the Southeast Asian countries. Those who didn't report such a steep decline in client numbers were more countries, for example, the Pacific Island, the rest of the Pacific Island countries, and then New Zealand, Mongolia, and Cambodia, who were not as affected by COVID as the other countries. Those countries that reported not much change in their clients were Australia, Japan, South Korea, and Tonga. So we can see a relationship there between how COVID has, how severe the COVID pandemic has been in these countries and its relation to the clients visiting clinics for SRHR. And then we've also seen a scaling down of SRH services. Howard was mentioning about the importance of the long-acting reversible contraceptives. We've seen that because clinics have had to take precautions for infection prevention, they have, some of them have scaled down their services to focus mostly on oral contraceptive pills and condoms. So even those who used to be on IUD or some other method and they needed, or depot and they needed an injection, it was not possible for them to come to a clinic. They asked their clients to switch to using oral contraceptives for some time, which could be provided over the counter without having to become in close contact. And in some member associations, they were able to deliver to the doorstep these contraceptives, like oral contraceptives and condoms. So in that way, some of the SRH services that were provided had to be scaled down. And of course, there was a steep decline in things like face-to-face training, information and education on comprehensive sexuality education, advocacy campaigns. Most of the things that needed face-to-face interaction have had to be canceled. Some of them, of course, can be done online, but at the community level, that is not really possible. So this has really been reduced down during this pandemic. Next, please. So despite all these difficulties, we've found that member associations have really quickly adapted to what people are calling the new normal and trying to find ways that we can still provide SRH services through the pandemic. So one way is through the service provision through telemedicine. We've seen 11 member associations who have initiated telehealth services. Of course, it varies in scale, it varies in the type. It could be as simple as using social media or using telephone hotlines, to having applications, apps that you put on smartphones, or using websites and such. So it has been, of course, it varies from MA to MA, but we've seen a big surge in MAs trying to embrace this new digital technology. Also for things like comprehensive sexuality education, and young people were already using it anyways, but I think the pandemic has really pushed us in this direction to say, you know, you need to really grasp this and make use of this opportunity to go digital and have online trainings, online curriculums of how to reach young people with sexuality education. And also there've been other innovative approaches like using Uber, kind of a Uber to deliver the contraceptives to the doorsteps, as I just mentioned. And also there was a very strong push for self-care. So we had been talking already about promoting self-care in SRHR, but I think this pandemic has really pushed us even more to think about what is possible and trying to introduce that at small scales with member associations. Next, please. Well, I just had a question in the chat box that says, what are you considering self-care? So self-care includes things like self-injecting contraceptives. We haven't really introduced that much to the countries yet, but you know, that is also one. And also medicated self-care abortion is another, also a service that could be done at home by yourself. So there are different types of things that you could do on your own at home, and we haven't really promoted that yet. And it was just starting to come. But with this COVID and new normal, I think there's a lot more that we could do in this area. Okay, thanks. Next, please. So next, please. So just a few anecdotal things. Can you go one slide back? So in the Philippines, immediately they started what they're calling a Your hotline. And it's a call-in where you can call in to get counseling. They also make use of Facebook groups because the platform is already there and many people are already familiar with it. They have times designated where you can chat with counselors. And then they also really quickly work towards establishing an online shop or online store so that some of the things could be purchased. And then home delivery, this doesn't mean having babies home delivery, but delivering the contraceptives to their home, as like you see in the picture there. Next, please. Indonesia MA would also took a similar model, and they called it the hybrid model. They still kept their clinics open, so you could have face-to-face counseling if you wanted to. They also created an app where you could have medicine prescribed to you through this app, and then the medicines could be delivered to your doorstep. So they sort of integrated and had both channels open for clients to access SRH services. Next, please. And so in the Pacific also, you know, they had very little COVID cases come to their countries, but nevertheless, they did have lockdown for some time. They established hotline and helpline in partnership with the Ministry of Women. They provided telephone and online services. They adjusted clinic hours so that they could, by extending the opening hours and ensuring infections control. And they also made use of social media to reach out to the communities. Next, please. One thing that happened in the Pacific was that there was cyclones that happened in earlier part of the year that really made a devastating impact on the lives of people in the Pacific, and then COVID came at the same time. So we integrated the work of the humanitarian response with COVID-19 pandemic response. So we had staffs who were deployed with the humanitarian response, also taking with them messages on infection control, how to prevent for the service providers also, and also for the communities, and providing SRH services and information at the same time. And this was a very good learning experience for us, and a way to integrate the kind of different types of services that might have gone separately, but because our member associations are really embedded in the communities, it was easy for them to integrate responses together, and it was a good lesson learned from the Pacific. Okay, next, please. So lessons learned during the COVID, one was understanding and building organizational resilience is really key, and not just, of course, now we're already into the pandemic, but I think we're learning that it is critical to work on it now instead of having a crisis come and you're not ready for it. So building resilience as quickly as possible is key when pandemics like this strike. We still have to see how the pandemic will impact sexual behavior and relationships, or the need for SRHR. We've heard, for example, in Indonesia, they are saying that maybe there will be a COVID baby boom next year. We've had anecdotal reports from Hong Kong to say that the number of young people who have accessed the Hong Kong Member Association hotline to ask about safe abortion services have increased. So it seems like there will be a lot of unplanned pregnancies, but we still have to see what has been the impact of COVID on SRHR in behaviors. Next, please. Yes, and as a summary, I have 5 things here, but I'll summarize it into 3 things. One is the role of CSOs and during pandemics like this. And as I mentioned in the very beginning, IPPF is a federation of member associations of local NGOs, and they are organizations that have been working in those countries for a long time with the communities, hand in hand with family planning and SRHR. So when something like this happens, of course, the government response is critical, but also it has to come hand in hand with civil society organization response. especially because it links to my number 2 point on the slide there, where I think CSOs, as CSOs, we are the people who could reach out to the communities and cater to the needs of those who may be more vulnerable in society or marginalized. We saw in the news how people who were on day work were cut off and they had to travel miles and miles to get back to their homes, or people who lost jobs immediately, they were thrown out into the streets, internally displaced persons, and so on. So, and I think the civil society organization, we were the ones who would be able to cater and move more flexibly and more faster, be more agile to the needs of the community people to reach out to to those who really need the help. And so the role of civil society is very, very critical in responses like this. Next slide, please. And my second point would be to say that, yes, this COVID has greatly changed the scene of how we operate, and we are not expecting it to change back very quickly. I think the situation that we have here will now continue for several years. It may become the new normal as we say it. So it is critical that we adapt and change as quickly as possible to this new normal and find ways that we can still continue to provide SRHR and family planning services to those who need it the most. And today is Human Rights Day, and family planning and SRHR are definitely the foundation and cornerstone of human rights. And it's a cornerstone of gender equality. If women are not able to make choices and control their bodies, how are they supposed to succeed? How are they supposed to contribute to economy? How are they supposed to make the best of their lives without family planning and SRHR? So I think, you know, on Human Rights Day, it's critical that we acknowledge that FP and SRHR are so critical to women and families and couples, that we need to be able to deliver and provide these services despite the challenges that we have as quickly as possible. And things like the digital health interventions that I shared earlier, making available the self-care interventions in their hands with knowledge and skills so that they can make use of it. Now, those things will be very critical for us. And then the third point, I'll put the number 4 and number 5 together. I think building resilience is key. And Howard also mentioned about the importance of data and new systems. I also think that it's very, very critical that we invest in building the capacities. And when I ask for investment, I would ask that it not be invested just in government systems, but it also be invested in building the civil society responses and building their capacity so that they can deliver to the communities who need it the most. Just recently in Japan, there was a survey that said of all the jobs lost, most of it was with women. About 80% of those were with women. So we've seen that COVID has a vast and probably a much more stronger impact on women in terms of economy. We've heard about SGBV cases. And so definitely interventions that protect women needs to be the center core of the COVID responses of all governments. So I think I'll end my presentation with that message. Thank you very much.
Wonderful. Thank you, Tomoko. Very interesting and inspiring presentation from you on this Human Rights Day, as you mentioned. And great to hear the perspective from civil society as a really important player in making sure services are accessed and women and families get the services they need. I'd like to move to our third presenter, Junice Melgar. If you could go to the next slide, I'll give you a quick introduction. Eunice is a medical doctor and is the co-founder and executive director of the Likhaan Center for Women's Health in the Philippines. Eunice, I'll turn it over to you. Please go ahead.
Yeah, thank you very much, Nandita. Just to say in this opening slide that Likhaan Center for Women runs community-based health programs in the poorest areas of the Philippines, including, I think what's being shown in the slide is urban. Next slide, please. When we started in 1995, so we are 25 years old now, our motto was creating alternative pathways for women with women. And currently, we have 3 core programs. At our very heart is community organizing, particularly of women and youth, for self-empowerment. Another key element is primary sexual and reproductive health clinics, provide not just contraception, but also maternal health care and birthing, management of STIs and HIV, vow counseling and referral, and lately adolescent sexual and reproductive health. That's the second element. The third core program is advocacy for gender equal policies and programs like sexual and reproductive health program now and comprehensive sexuality education in the Department of Education. Next slide, please.
Eunice, before you continue, I want you to just speak as close into the mic as you can and louder. I think it's a little bit difficult to hear you.
Okay, I will. I hope this is loud enough.
This is better. Go ahead.
Yeah, actually, I think there was a dark slide before this one. The dark slide actually representing the shutdown. Our program shut down for 2 weeks because of the declaration of the lockdown. And it took us 2 weeks actually before we could assert that yes, we are an essential healthcare, and we secured permits to operate and we installed infection control protocols and trained our staff in COVID precautions. So that is why that is the black spot. Next slide, please. So this is just a brief orientation of the Philippine situation in COVID. We had a peak in July, but we are declining very slowly. So that December 2, this is the situation of December 2, we have levels of 10 to 12,000 per week. That is still high. And that is scattered all over the Philippines. And we don't really know whether our country, our government will be able to control it. Please. Next slide, please. This slide actually just depicts the structural barriers to essential healthcare services, including family planning. And the pictures depict 2 parts are actually because of the very stringent and militaristic approach to COVID control. You have small level lockdowns that prevent even sick people and pregnant people from passing. You have military vehicles roaming the streets and actually engendering intimidation and fear instead of solidarity. And the third picture with a boy actually depicts how often we are visited by typhoons, like this is typhoon season now, and also, of course, the endemic poverty in the country. Next slide, please. Next slide, please. So how are we sustaining our programs, our sexual reproductive health programs, including FP? And I would cite actually the human factor, the human element, 3 human elements. Number 1 are the community health workers. So we are based in the community. We have health workers, we have health organizers there who act like sentinels. They detect problems in the community, they provide information, and then they link they link patients who need help to us, to other agencies or government resources. So that's the first vital element. Next slide, please. Next slide, please. So the picture does not show, but that should have shown a community health worker who is more of an organizer. It is an organizer and community health worker rolled into one. So these are better trained community health workers in primary health care for women who do community education, who counsel women on sensitive issues like abortion, like violence against women, like adolescent sexuality and contraception, which is depicted in the slide, but it's absent. So these community health workers are now the pillars of the clinics, and they actually do the screening for COVID in this clinic. Next slide, please. Yes, and the third very critical element is our provider. Mainly, these are nurses and midwives who were trained in the full range of outpatient family planning care, apart from other sexual reproductive services that I mentioned. No? So actually the efforts of the healthcare provider, the demobilizers, and the community health workers enabled us to recover the services used to number like 4,000 in a month. In April, that was down to 2,000, 50% of our monthly capacity. Because of them, 6 months later, in September, we are numbering about 70% of our 2019 capacity. So this slide just shows our constant visitors now are men. They're coming not for themselves, but they come because they are the quarantine pass holders, and they get the pills and other prescriptions of their wives. Next slide, please. We have also been adapting, apart from maintaining our clinics, but in a very different sense. We have also adapted activities. And I will mention just 4 of them. This is the first slide, shows consultation for reproductive health. The more senior staff who cannot handle day-to-day clinics actually run this telehealth 2 hours every day for 5 days. And in September, we had the highest of the consultations was contraception by young women. So this is the first time that we encountered young women who were mainly telephoning for self-care, basically for oral contraceptive and emergency contraception. Next slide, please. A second initiative that we started is really policy dialogues with influentials. Since this began in May, and in August, we had our family planning dialogue with key officials, national officials, also with attendance of international resource persons, but also with many local persons who are experts. And we actually tried to sort out barriers, like for example, the ban on young people 21 and below from going out of their house. So that was a key problem before. This dialogue actually pushed our health officials to raise this to the task force COVID. So now young people 15 and upwards can go out and seek help. No? So this is an adjustment. Next slide, please. Adaptive measure is actually this chat bot, an artificial intelligence bot. The name that we have given it is a unisex name, Kai for kaibigan. And Kai is able to respond to questions on puberty, on pregnancy and childbirth, on contraception, on sexual violence, and then it can be linked. So the bot also links them to if needed. So we have had, I think, over 1,100 conversations with users through the bot. Next slide, please. Next slide, please. And this is the fourth adaptive measure. It's really not new. This is just a resumption of what used to be like a core service of ours, which is outreach. But this was an outreach 55 kilometers away from us. And this was a request solely for family planning, not just by the women who live there, supported by their village officials and also their municipal health officer. So it the local government unit actually requesting us to provide family planning because the local government unit was focused on responding to the COVID crisis. So we had 22 women here, and 12 of them opted for implant, and one for IUD. The others were for injectables. Next slide, please. These are just quick reflections. These are not comprehensive assessment, but on our experimentation with adaptive methods, we have learned and appreciate that teleconsultations actually have enabled us to reach young women, also to focus on self-care. So self-care now augments the provided care, which is now starting to focus more on long-acting methods. So you have clinic-based on large, and then you have teleconsultations that are increasingly more on self-care. The other important thing from our experience is that there really is space for local government units and CSOs to collaborate in areas where COVID continues to be high, because the collaboration will allow the LGU to provide the much needed COVID response, but also essential healthcare like family planning also at the same time through CSOs like Likhaan. So these are the things that we are trying to develop, and we are at the point of looking at the experience very closely, so we can develop them not just to complement all the different methods, but I think more importantly, as Howard said, also to make sure that not only are everybody safe, the patients and our staff are safe, but that the care is quality care. And yes, that there is data that can guide evaluation and monitoring and improvements of the services. This is the end of my presentation. I'm sorry for the sound. Thank you very much.
Great. Thank you, Eunice. That was excellent. I am mindful of the time, but we have one more presentation, and I think it's going to be very interesting. So I would like to continue for the next presenter, Rika Morioka from Myanmar Partners in Policy and Research. Rika, over to you.
Thank you very much. My name is Rika Morioka. Can you hear me well? I'm sorry.
Yes, we can hear you well, and keep speaking right directly into the mic as you are.
Good. My name is Rika Morioka, and I'm from Myanmar Partners in Policy and Research. I've been working in Myanmar for about 15 years and in the field of public health field. Next slide, please. MPPI is a locally registered organization, and since 2013, we have been working closely with Pathfinders for the last 7 years, and also have partners as FP 2020, UNFPA, and other agencies. You can see a photo of our first family planning best practice conference in barrier analysis on the left. You might find some familiar face there from IBP and other members. Next slide, please. So today I have 3 points to make. One is the challenges are not from the disease itself, but the government responses to the pandemic. That's my point number one. Number two is that emergencies and crises actually like COVID-19 accentuate the existing issues that we have been struggling with. And number three, the points that we like to make is actually created many opportunities, as previous presenters talked about. So I would like to talk about our experience on that. Next, please. So the first point is that challenges all come from government responses, not the disease itself. I want to emphasize here that I'm not criticizing the government response at all. Every nation is struggling to balance between COVID and functional society. And some choose to ignore COVID existence at all and then pretend nothing is happening. And the other extreme is to close down the entire country and shut down and every activity and people just ask people to stay home. Myanmar's response tend to be on that latter, asking people to stay home and shut down all the functions of the society. Next, please. So in terms of health, we work in a rural areas in Myanmar, and in terms of health, we have seen very little impact in rural areas. Although it's starting to spread in recent months in some areas, the most health impact has been seen in large cities. And therefore, there's in our project area, there's no death. People are relatively moving about okay. And nationally, daily confirmed cases is about 1,000 to 1,500. So in health-wise, the impact is rather small in our townships. Next, please. What we see, though, is large economic impacts, as you can imagine. We've been hearing stores shutting down and transport not sending their products to cities. So I hear people discarding tomatoes and vegetables because they cannot sell them. In the area that we work has green tea production, and then they have been forced to throw their products away. And so the impact is quite large on the economic impact, front. Next, please. On our implementation of projects, the hardest part is the government restrictions. We are prohibited to travel to project areas, so travel restrictions and approvals from the government is also delayed, and then activities therefore are delayed. And in places where we work, we hear people are tired and fatigued by the announcements that government make with the loudspeaker. So they are tired of hearing it, and it's spreading sort of vague fear rather than concrete information. So that also affects the implementation. Next, please. So young people, how young people impacted by this COVID-19, obviously they are ordered to stay home so that the people cannot go and buy things, so including contraceptives. And then we work with the young people, so we're working on AYSRH, and then that would make it even harder mostly because they want to hide. They cannot go out and openly purchase contraceptive, but the fact that less people on the street makes them visible, so that increased fear is really preventing them to access services or buy contraceptives. Another point that I can make is that we are increasingly dependent on the internet in implementation, because we cannot physically go to the field. So we are reaching more and more people who have the means to have the internet, and young people in the rural area have much less access to the internet. So we are estimating about 30–40% of young people in rural areas do not have the internet or telephone, or they're sharing the telephone with their family members, or they shared not enough money to buy the internet constantly, to be connected constantly. So those are the issues that we are facing. And next, please. In terms of family planning commodities, early on in the pandemic, we saw some disruption, and we heard that some commodities are not coming into the town, but I think we have getting much better than it used to be. And the point that I would like to make is that the issue is not so much about the availability of commodities in the first place. The real issue is the ability for young people and younger women to access the service. And then I'll talk about that further in the next section. Next, please. So my point here is that COVID-19 and other emergency accentuate the existing challenges that we are trying to meet. And so I'll talk about what we are struggling with in Myanmar. Next slide, please. The point that I would like to make here is that the access to information services is very hard, not because the services are not available, but because of the social environment and stigmatized SRH services and taboo subject of discussing AYSRH. So in that environment, teenage pregnancy is rising quickly, especially in the recent years, and reduced general physical movements due to COVID-19 makes it more difficult because people are watching each other, and it increases the visibility of individual youth. Next, please. This is one of the example of how young women are having a hard time accessing contraceptives. This is the quotes from left side is a sex workers, and many people are asking men to buy contraceptives, not because they want to, but because they feel prohibited socially, informally, going to access services. So they're asking boyfriend or other taxi drivers or pimps to buy contraceptives. And so the consequence of this is that the use of contraceptive is not in their control, and the method of choice is also they'll have a little choice over this, and then no accurate information about current use and the side effects will not be given directly to women. So there are many negative consequences of this, asking male partners to buy contraceptive. Next, please. So I'm going to try to go quickly. This is also another data from our interview that people don't want to talk about sexual health, and therefore they don't want to. They think that child marriage, they can always get married if they have if a girl gets pregnant. That is the attitude, very common attitude in rural areas. Next, please. As a result, another result of this is that no matter how many times or how hard you try to train teachers for comprehensive sexual education or train healthcare providers, they tend to have a hard time using those skills because the social environment they're in would not allow them to talk about AYSRH. So they themselves don't feel comfortable using contraceptive, and they themselves don't want to, even though they're trained, they don't want to talk about AYSRH. So they tend to ask their colleagues, other colleagues, to teach or provide services to avoid that discomfort. Next, please. So the results of this social environment, which makes it hard for young people to access service and information, is high level of unsafe abortion and death from it. Unsafe abortion is the second largest cause of maternal mortality in Myanmar, and it's estimated about 250,000 a year. And I'll talk about this because it's very important to think about what this number means. But as earlier presenters talked about, because young people have a hard time accessing services, we can expect the higher number of deaths from unsafe abortions in next year. Although it's hard to measure, I think that would happen, unfortunately. And the next slide, please. Oh, sorry, would you go back to one? I was missing one. Yes. So I want to talk about the number 250, about 250,000 women have unintended pregnancies. And I want to go back to the number of COVID. The number of deaths from COVID is 2,000, about 2,000 people right now. And if 1% of death increase due to unsafe abortion because of the difficulty accessing services, then that would be 2,500 women dying from unsafe abortion. So that's the same number of the COVID deaths currently we are facing. So that's something to think about. Because of the lockdown and the response to COVID is causing 1% increase in death from unsafe abortion. That is higher than the COVID itself. If there would be 10% increase in unsafe abortion death, then that would be 25,000, 10 times worse than the number of COVID deaths among young women. And I'm wondering if this is definitely something to think about. The number of deaths is much higher due to the secondary effects from the lockdown. Okay, the next slide, please. As you know that the GBV is increasing, but it's hard to see. It's not visible on the ground as much as you would expect. That's because of the awareness, and the concept of GBV itself is new. Concept of gender itself is new. So it's difficult to assess for the people to know. But a lack of loss of jobs and economic hardship is causing to alcoholism. And then that alcoholism is likely to lead to a GBV. Next, please. So the opportunity, I want to talk about the opportunities that we found in COVID time. Please, next. The use of technology, as everybody else has been talking about. But one thing I wanted to mention again is that, yes, good news is that we can adapt and implement. But if communication has been even more frequent than it used to be. But we have to adjust our expectation of whom we can reach using the technology. In the rural areas, and young people tend to be poorer, rural areas tend to have less access to internet. So we would end up reaching certain populations, biased populations, and that has to be, that expectations has to be adjusted because we're doing this because we have no other choice. And we would do what we can on the ground to reach people, but we need to adjust our expectation that not all can be reached, and then poor people can receive information and services. So I would vote for combination of in-person interactions and use of technology as much as we can. Next slide, please. So we have been integrating COVID-19 and GBB and AYSRH as much as we can. COVID-19 has been providing us some entry point for discussion in the community, and then GBB it's gotten easier to talk about GBB, and dialogues about gender power dynamics and women's rights, and along with young people's rights. So that's an opportunity. And then next one, please. We have been trying to engage community members in dialogues about AYSRH and gender equality. And the COVID-19 has been giving us that opportunity as involve different types. So the point here is that we're not only working with the youth, but we're educating adults surrounding youth. So we're working with parents, we're training teachers and community leaders and everybody else that affects young people's behavior. Next one, please. So as you can see in the next diagram, that we're trying to have champion development among parents and community leaders and other members, so that whole environment would allow young people to access service and information. So the next one, please. So my point has been that the government response is the challenge, and then emergency and crisis like COVID-19 has been heightening the existing issues that we have been trying to address, and the opportunities are there, but we have to modify our expectations. Next, please. And that will be the end of my presentation. Thank you very much.
Wonderful. Thank you so much, Rika. And thank you to all the presenters and for participants for staying on the line. Unfortunately, we've gone over time, so we will skip the questions for today, though I think some of you posed and received some responses directly from the panelists. Please see additional information. You can find WHO COVID-19 guidelines and resources at the links below. In addition, we've developed a specific question and answer on contraception. It's available in English, French, and Portuguese. And finally, please do visit the IBP Network platform and site, ibpnetwork.org, where you can join the COVID-19 Task Team. We'll be posting this webinar, materials, and various resources to help you in your work. Thank you again to all of our panelists and presenters for your excellent work and taking the time out of your schedules to share your experiences with us today. And thank you to our participants for staying on the line. Do stay tuned for more regional webinars from the IBP Task Team coming in 2021. With that, I wish you all an enjoyable rest of your day and evening, and happy holidays, and we'll see you in 2021. Thank you. Bye.
Thank you. Bye.
Bye.